I think we can start, Daniel. Dana.
Yeah, okay. Hi, everyone. Thank you for joining us for today's research seminar series. I'd like to welcome, I think, from Germany, Willi Wagner, who will be talking about the synchrotron radiation-based CT for ultra-high resolution multiscale lung imaging. So, Willi, I'll get you to introduce yourself and then, looking forward to your talk.
Dania, thank you very much. I hope the audio is working fine for you. Many thanks for inviting me to give a talk in this research seminar series. And as you have already read probably from the abstract, I want to share a little bit on our research that we are doing in a multidisciplinary and multinational research collaboration on synchrotron imaging for the lung. From very small resolution up to whole organ scale imaging with the ultimate goal of one day using synchrotron-based CT as a diagnostic tool for lung imaging or pulmonary imaging in patients. We will start off in the talk with a little overview about the conceptions that we thrive for. One goal is to integrate different imaging modalities in order to gain a maximum understanding about lung pathologies. And what I mean by that is that we are using mainly synchrotron high-resolution imaging to gather 3D information about lung structure, because the lung inherently has a very complex three-dimensional structure and can not be fully understood by just looking at cross-sectional imaging such as histology or electron microscopy. So we are trying to integrate that information with a very high spatial coherence into the three-dimensional scans that synchrotron CT allows us to obtain. This second idea is to use very high resolution CT image by means of virtual histology to incorporate the three-dimensional information on the histologic scale. Histology, so the cross-sectional microscopic imaging with specific stainings, is the gold standard in clinical routine when it comes to assess tissue. And our idea or goal is, and not ours, but many other research groups are trying to use synchrotron imaging to gather the three-dimensional information. But the pathologists, so another discipline, I am a clinical radiologist. The pathologists are the ones who look into the microscope and look at the tissue, and they are not used to CT images, to grayscale images. So correlating and integrating information from microscopic imaging into the synchrotron scans, that's basically what virtual histology is about. And I think in the future there will be machine learning and AI will be used to artificially stain the synchrotron images and therefore allow the pathologist to also understand and read those CT scans, because I, as a radiologist, I'm used to reading CT scans, but the pathologists aren't. They are at home at this scale. I'm not at home at synchrotron resolution scale. So it's a very interesting field between radiology, pathology, and of course, the technical expertise that neither the pathologist nor me as a radiologist is used to. So we need physicians such as Juliana Trombo or Christian Dulin, who I will get back to within this talk. And the ultimate goal is that by using multiscale imaging, meaning coming from the clinical scale and looking at the entire patient in a clinical CT, and then closing the gaps between histology and the entire patient, I think this can only be done by synchrotron imaging on a multi-scale basis. And I will show you what I mean by that. So in this talk, we'll start from the small stuff and then move on to the bigger stuff. And at the end, we will look at what we envision a clinical setup could look like for imaging patients. So let's start with the integrative part. And here I want to introduce to you which facility we are cooperating with or working with. It's the Elettra synchrotron in Italy, quite old already, but a lot of expertise there and a lot of flexibility also there when it comes to planning and conducting experiments. I don't have to talk about this a lot, I believe. I will get onto thin ice, but you are all probably familiar with how the synchrotron is set up and basically how it works. So what I have understood so far is that electrons are accelerated and then put into a storage ring. And at each side of the polygon, you can do different experiments. And one of these experiments is imaging, and that's what we do. And here on this slide, I have put out what a clinical CT looks like on a schematic. So we have the source, the X-ray source that is circulating around our sample or patient, and the energy absorbed by the patient or the sample is detected, the rotating detector, and we don't get any information about the phase shift. We have to use a synchrotron, as you know, and this is very basic stuff that, as far as I have understood it, the phase shift happens at the interfaces of different tissues in our samples or patients, and the in free propagation-based imaging, we actually measure the interferences between the shifted photons. And the further we move our detector away, the higher the signal gets, or to put it differently, the structure that you are interested in within your patient or your sample, you can calculate a perfect sample to this detector distance. And an alveolus, the smallest unit of the human lung, is about 60 to maximum maybe 200 microns diameter. And if you calculate that to the perfect sample to detector distance, you end up a few hundred meters behind your patient. So this is something that we have to keep in mind whenever we are thinking about building an infrastructure to look at patients and use pulmonary CT, synchrotron-based pulmonary CT. We're talking about a large facility that we need to build. Yeah, and then on the right-hand side here, I have put down some of the perks of different imaging modalities. And what synchrotron CT is delivering for us is basically the three-dimensional structure at a very high resolution, and we can change that resolution, of course, with limitations to our field of view in whatever way we want. Light microscopy, like I said, the gold standard of looking at tissues in clinical and biomedical field. It's very well known and has been around for 100 years. So we need to whatever pipeline we are building, we need to build it around histopathology and light microscopy. And electron microscopy really goes into the deep end of spatial resolution. And our idea is to integrate these modalities to reach maximum information within one sample, from one sample. And here's an example for you. That's just healthy lung. And the three-dimensional structure that I've laid out for you is derived from synchrotron imaging. It's a simple volume rendering. In blue, you can see conducting airways of the lung, which can be quite big. This is a healthy porcine lung, so from a pig. And the pig didn't have any disease. In pink, you can see the cartilage components of the bronchial wall. The bronchial wall, as a matter of fact, is not displayed here in the volume rendering. So the blue structure is the lumen of the conducting airways. And we have laid out one pulmonary arterial vessel in red, which is accompanying these smaller conducting airways into the periphery of the lung. Also integrated in this example image is a histological slide with the pinkish structure at the interface here of the volume. It's the #1 main staining that is being used to do morphological investigation on any tissue. And again, the airway components, so the stuff that is in the living animal would be filled with gas, is void space here. So you actually only see the lung tissue. And also spatially integrated is the deep end of our imaging pipeline. It's scanning electron microscopy, which really shows you individual cells. In this case here, on the bottom right side, you can see, let me see if I can, you may see my cursor right now, and that's individual chondrocytes within the cartilage of a conducting airway. Yeah, the basic idea is to build this imaging pipeline around histological specimen. And histological specimen are made from formalin-fixed, paraffin-embedded tissue blocks, FFPE blocks. That's what the pathologists work with and do their diagnostics every day. And within the archives of any pathological institute, there are hundreds of kilos, if not tons, of paraffin-embedded tissues of various cancers and disease. And 99.9% of them have only been looked at with microscopy, meaning that only a little portion of that tissue has been investigated so far or looked at so far. So there's a huge treasure lying in every pathological department in the world because it hasn't been looked at with ultra high resolution imaging yet. And why is Synchrotron working so well for this? Because of the phase shift. It is very powerful in soft tissues where we have only few or very small differences in density of the material. But at the interface, the phase shift is happening. So we can get proper contrast from this tissue using synchrotron CT. Now you can image entire blocks to get an overview of the tissue that you are dealing with. And then you can identify hotspots. And you can either do a local tomography, or you can go ahead and do a targeted punch biopsy of that region that you're interested in, and you can scan it at higher resolutions. The one thing that's a bit tricky, or can be a bit tricky, especially in the lung, is air inclusions. So whenever within this paraffin block, and paraffin is basically candle wax. So we embed the tissue in candle wax in order to slice it later. Sometimes, especially in the lung, you get air inclusions within this candle wax, and it creates a lot of phase signal, and can be negative for our morphologic or diagnostic purposes. So you try to do the embedding as air-free as you can, working with vacuum pumps. But still, sometimes you can't avoid it. And we usually identify regions where there's few air inclusions. And in order to, if you have identified a region of interest and you now want to get your histologic slice exactly from that region, you can do the calculations by looking at your FFPE block scan. And then we have found in order to reach your designated or envisioned slice, you have to keep the temperature of your FFPE block stable when you're doing the microtome sectioning. And if everything works well and you have an experienced technician who is doing the sectioning, you may hit your region of interest with an accuracy of so far 15%, more or less, which is good because usually your zone of interest is a little bit larger. And once we have sliced our designated or envisioned piece, we then do the staining. And it turns out that there is always some micromechanical deformation happening to your tissue when you do the microtome slicing. But you can correct for this by means of elastic registration, and then you can put your digitalized micrograph into the three-dimensional structure. Not only do you have precise information about the type of tissue that you are looking at, but you can also propagate the three-dimensional structure or of any given piece of interest. And if you are still not satisfied about the amount of information that you have, we have then developed a protocol of doing electron microscopic imaging of the same tissue slice. So first you do your specific staining, and then by a protocol of a heavy metal impregnation and sputtering on a charged glass slide, we conduct electron microscopy to really get into the ultrastructure of the tissue. And also here in this talk today, and I believe with you in Australia at the moment, is Lorenzo, who integrated atomic force microscopy into this imaging protocol. So he is able to gather micromechanical information about viscoelasticity of any given tissue type and integrate this into the three-dimensional plot. But I will show you in a second. Here's just some other examples of healthy lung so far, integrated tissue morphology, and the amount of information, additional information that you get in the lung if you're using three-dimensional imaging is vast. Here, for example, just septal tips of alveoli. So the end of an alveolus is more or less like a polygonatic bubble. And if you slice it into 2 dimensions, the entrance ring of an alveolus will only look like a tip to you. But if you integrate 3-dimensional information from the synchrotron imaging, you can see a very complex spiral structure that is actually emerging from those septal tips. And that's what we call the axial connective tissue system of the lung, which basically keeps your alveoli open during breathing. So the lung, if you think about it, the lung structure is astonishing. You have the surface, your gas exchanging surface in the lung is as big as a tennis court. And it's all packed into your thorax, very small little bubbles made up of wet tissue, and it's not clumping together. Imagine putting a tennis court of wet tissue paper into your lung. It would all collapse and stick together. But this fine structure here, the axial connective tissue system, balances the surface tension forces of alveoli. And that's what keeps it all open and working. So it's a structure of interest that so far could not be investigated in its 3-dimensional structure. But with synchrotron CT, it can. Here you see the junction of a conducting airway into an alveolar duct. So the actual hallway where the alveoli to the left and to the right come off like rooms. And you can appreciate the 3-dimensional complexity of this unit only by looking at it in 3 dimensions. So if you would only have the purple 2-dimensional tissue slide, you would not understand what's going on here. Of course, not only morphologically, this 3-dimensional information is interesting, but it can also be assessed quantitatively. And one disease area that we are very interested in is pulmonary fibrosis. It is basically a scarring of the lung. It's a failed response to wound healing. You all know if you cut your finger, you will get a scar. And if that happens in the lung, the flexibility of the lung in every breathing cycle is inhibited. Basically, a fibrotic lung, if you would compare a normal lung to an air balloon, a fibrotic lung would be a hot water bottle. If you are sick, you take a hot water bottle into your bed to keep warm. And that's how you can compare the two. You cannot blow it up anymore because it's scarred. And this scar tissue results in a shift in the volume fraction of tissue compared to air spaces. You have more tissue in your lung. And this can be quite well be assessed in the 3-dimensional space. And here we could show that the 3-dimensional assessment of 3D volume fraction of tissue correlates very well with radiological scoring of the severity of fibrosis. Not only can we tell that more tissue volume fraction means worse fibrosis, but we can also tell you exactly what's behind the increase in tissue at any given space, because we are able to correlate or integrate directly the histopathology into our images. And in this panel, we can see collapsed air spaces, infiltration of inflammatory cells around blood vessels, and also actual fibrotic hotspots that we find predominantly in the periphery of the lung. That's lung surface here. And in the periphery of the lung, fibrotic foci are contributing to the increase in tissue volume fraction. Another very important hallmark of pulmonary fibrosis is so-called honeycombing or microhoneycombing. And here we are looking at mouse model data, so a small animal model of lung fibrosis. And till this investigation, it was unclear whether the mouse model would actually exhibit honeycombing. Honeycombing basically means that a little piece of the lung is, you have like cystic structures within your lung that are developing. And by using the three-dimensional information, we could show that mouse models actually do not exhibit honeycombing by means of a closed cyst, but rather the dilatation of alveolar ducts. So far, we termed it traction alveolar ectasis because enclosed cysts are not developing in mice. That's one drawback of the mouse models that we are using to investigate pulmonary fibrosis. And so far, only synchrotron imaging was able to show the connectivity of these structures. And of course, again, we can integrate histology to really prove that we are looking at the right structures. And we can even go down a scale and look at the same thing by electron microscopy. Where the synchrotron imaging really came in handy was when we looked at fibroblastic foci. So if you would look at pulmonary fibrosis as a cancer disease, if you would look at it as if it was cancer, the cancer cells would be your fibroblastic foci. These are the bad guys that are creating the stiffening of the lung and the laydown of an excess amount of connective tissue within your organ. And so far, they have only been studied in mouse models in 2 dimensions. Now, synchrotron imaging gives us the opportunity to study them in 3 dimensions, to look at their clustering, to look at their structure, whether they're interconnected or not. We found out there's no interconnection, and that they are usually laid down in a pearl necklace-like structure. One surprising finding that came up when we looked at our mouse model of pulmonary fibrosis was the presence of crystalline structures within the airways of the lung. And that was actually picked up in the synchrotron scans and not in the histology. So that's one good example of how this pipeline can be used to drill down on findings. And we were then able to access those regions where we saw these crystalline structures light up in synchrotron imaging. Of course, again, this is thanks to phase effects. Looked at them by means of light microscopy, studied them in ultra high resolution electron microscopy, where we were able to really see the complex structure of these crystalline deposits. And then you are not diminishing immunogenicity of your sample by exposing it to synchrotron radiation. You can still do immunohistochemical staining to really let you know about the molecular origin of your structures and findings. And we found out that those deposits were YM1 positive It's like an immune reaction of the lung, but that's too high. And there is a enzyme being secreted that's way too much secretion, and then the amount is so high that it will form crystals that can inhibit airflow in the very small airways. Here's just an example of of how we use this integrative imaging. And we then stained for alveolar macrophages, cells that are eating deposits, and we could find those crystalline structures within the macrophages and prove that they are not an artifact of our preparation, of our sample preparation, but they must have been in the lung when the animal was still living, because cells ate the crystals. Here comes in Lorenzo, and Lorenzo went a step further and actually integrated atomic force microscopy into this imaging workflow. And what AFM does, it lets you know about how stiff the tissue is, but not the overall tissue, but you can really probe down on very fine structures of the lung and find out which structures are contributing most to the overall organ stiffness. And it is plotted as bars. The higher the bar, the stiffer the tissue. And it could really show you where the stiffness of the lung comes from. Yeah, so far so good. Let's move to a higher scale, and I have to look a little bit on time. I have told you now what integrative imaging means to us and how we think it will enrich our understanding about lung disease by integrating different modalities into the same image or readout. And virtual histology basically goes hand in hand with it. And it's the idea of pathologists and radiologists using ultra-high resolution synchrotron imaging to close the gap between histology and clinical imaging. And one example where we did such thing, where we went down the scales and tried to follow a disease marker, was when COVID-19 popped up. And we here have a COVID-19 patient who was doing very bad and received a clinical CT scan. And it was contrast enhanced, and panel F, you can see the lung window, and you can see some consolidation, some filled up air spaces in the back of the lung. And you can see a quite well aerated area in the center of the lung. However, this lung, which was not consolidated and should help the patient, it was not perfused, which was very surprising. And in the beginning of COVID, when the virus was still very bad, when there was no vaccination, this feature of the disease killed people, because usually the lung has a mechanism of coping. It will send blood to the area of the lung which is still ventilated, in order to facilitate gas exchange and keep the patient alive. COVID messed with this system, and multimodal imaging, cross-scale imaging, allowed us to investigate those exact regions where this mechanism was put out of function. And we found that small blood vessels, the very small blood vessels in those regions, they were diseased. Some of them opened up. There was microbleeding that you couldn't see on clinical CT, but on high resolution CT imaging, you will find these spots. and because we integrate the information and know exactly where we are in our specimen, we are able to draw conclusions. We found microbleeds, microangiopathy, and microthrombi, so meaning a clotting of the very small blood vessels. What we also found in this region was that some of the opacities in our clinical CT scan was not just infiltrative inflammation, but developing fibrosis. We come back to fibrosis and we see those fibrotic areas again in the periphery of the lung next to our microangiopathy. So here the air spaces, the tissue is diseased, and the little lung that was left for the patient, the blood vessels were attacked by the virus, and that's what made the disease so bad. Within the corona period, a couple of German pathologists went ahead and used synchrotron imaging to image the entire lung of patients. And here again, this cannot be facilitated with any modality but synchrotron. They were able to do local tomographies within an intact lung in order to look at the entire organ, but also at very small scales without destroying the specimen. And that came in really handy in helping to understand what was killing the lung. Here we looked at a healthy lung from a donor. However, a diseased COVID-19 lung would look very different. So this is still what we see in clinical routine imaging. We see vast consolidation of the lung, but synchrotron imaging gave you the opportunity to then zoom in to regions of interest and give you a unprecedented resolution while still knowing where in the entire organ you are at. And what we found out there was again aberrant blood vessels, so a disease of small blood vessels. And you can pick this up in these images. There are way too many blood vessels around the airways and also around the larger blood vessels of your supplying arteries. And because we are gathering three-dimensional information, we can look at this thing, we can look at volume renderings. And what we found out there was that pathologic connections between the blood vessels around airways and between the blood vessels around our larger pulmonary arteries are being formed. And the blood, which should go into the lung and receive gas exchange, it's shunted directly to the heart without receiving any gas exchange by so-called plexiform lesions. It's those guys here, these proliferations of small blood vessels. So your heart is pumping the blood through the lung, but not reaching the periphery where the gas exchange is happening. And again, this complex structure and this complex phenomenon could only be understood by using multiscale imaging, where you can really follow the tracks of these small individual blood vessels. The courtesy goes to ESRF and, like I said, Dan Jonik and Max Ackermann, the pathologists that I was lucky to work with in this project. Now, is there any possibility to take all these advantages and use them in live patients, contribute to precise diagnostic in patients who are still alive? We believe yes. And this brings me to the last piece of our project. And this little graph here, I want to show this is not energy prices, but it is ultra high resolution CT publications on PubMed in the year of 2021. I called this up. It's skyrocketing. People are interested in higher resolution when it comes to CT imaging in general, and especially in the lung. Why is this so? In clinical CT at the moment, we have resolutions of around about 500, maybe 250 micrometers. But the magic is happening below that. I have told you 60 to 200 microns is one alveolus. So 1 pixel in clinical CT is more than 1 alveolus. And whatever is happening when gas is, alveolar gas is displaced, you have an increase in density and you get so-called ground glass opacity. That's ground glass opacity, that's normal lung. Normal lung structure, we know what that looks like, but many different pathologies can result in ground glass opacity, okay? And we need higher resolution in order to really understand what's going on in the lung. And if we would have had ultra high resolution imaging, we would have much quicker understood, for example, what COVID-19 was doing. It took a long while until we understand why it was so bad for the people. And the idea is to scan a patient in the synchrotron scanner. So actually on impulse of Christian Dullin, we just tried what we could do. And in Heidelberg, we have developed a phantom that was actually designed to look at fresh lung in clinical CT scanners and in clinical MRI scanners. But Christian's idea was to take this phantom and put it into the synchrotron. And it did take a little bit of adaptation to mount it in a vertical way because it was used to laying flat. But we managed to do it, and we were able to look at the same lung. It's a fresh lung, it's not fixed from a pig. And we were able to look at it in the synchrotron and then look at the exact same lung in a top of the line clinical CT scanner. And we were able to compare the image quality of the both. And as you can see already, like you guessed, this is clinical CT, this is synchrotron CT, and the image quality is way superior. You have much more detail, especially when it comes to small structures, not only healthy structures, but also, in this case, artificially induced lung nodules. Per se, the precursor of lung cancer. Here's a little schematic of the setup that we have. So this phantom is working with negative pressure. The lung is inflated by evacuating the space around it, just how it is working in our own chest. That makes it very nice, and it's fresh lung, so you know what you're looking at. We found out that synchrotron CT is very sensitive to small differences in density by injecting different concentrations of iodine-enhanced agarose nodules into the specimen. And we compared different morphologies, so we tried out a little bit to simulate what we are dealing with in the clinics. So in the clinic, we're dealing with little nodules, and we are trying to tell the patient or the referring clinician, is this a benign nodule? Will this harm the patient? Will this develop into cancer and eventually result in bad disease and death? And we look at the morphology, we look at the interface of such nodule, we look at substructures, And in this case, in the clinical CT, we would call it a subsolid nodule, solid component with ground glass around it. Solid component with ground glass around it. But looking at the same nodule in synchrotron CT, we can actually see we have accompanying micronodules. So another feature would be spiculations. This could be seen as a speculation here. Synchrotron-based CT tells us, no, it's not. It's just part of an interlobular septum. Different finding here would be acute lung injury. So at the very beginning of bad lung inflation, you have acute lung injury. And this is a clinical CT of it. This would be our lung looked at. Our model lung looked at in clinical CT and synchrotron-based CT. And I have to apologize a little bit for the artifacts here. This was from our very first experiment. But you can see the amount of additional information and fine substructures that you can identify also in this disease model. Here's yet another example of lung nodules that you can, and especially in this example, I wanted to emphasize the border and the substructure. So you can see substructures in these nodules here that in clinical CT cannot be appreciated. And that's anatomical detail that, in my opinion, will help us in the future to characterize lung nodules in patients. That's the amount of detail that you get. And whenever I show those images to normal radiologists, it blows their hair back when they see the amount of detail that we get. Now, when we show these images to clinical radiologists and tell them, please judge image quality based on different substructures within the lung, we find out that they like synchrotron CT scanning because for diagnostic purposes, because the resolution and image quality is superior. And when we look at the numerical data, especially when it comes to radiation exposure, I want to show you this slide, which here basically we simulated lower radiation exposure by using less rotations of the images that we acquired. We found out that by increasing the sample to detector distance, we reach higher objective image quality, and that the image quality is still quite good when we decrease radiation exposure, in this case, the number of projections used for the reconstruction of the image. And this also holds true if you look at the image quality by means of radial average power spectra, where the worst image that you can create would be a synchrotron image without phase retrieval. That shows you how much the contribution of the phase effect to our image quality is. How could a potential setup look like to use it as a diagnostic tool for patients? Well, it will not be our primary modality to investigate lungs. It will be an add-on diagnostic tool when we identified a suspicious or unknown nodule within the lung of a patient. We would then subject him to a local tomography of that lung region in synchrotron CT to characterize that nodule and avoid an invasive biopsy. So you could go ahead and stick a needle into the patient's lung to grab a little piece of the tissue and look at it under the microscope. However, most of the patients with lung disease and lung changes they have difficulty breathing. They are in a bad condition, and they could suffer lethally from an invasive biopsy. So any chance you can avoid an invasive lung biopsy is good for your patient. Some technical developments and adjustments that we made around the years. One of them was hardware upgrade to the sample rotator, where the people from the Italian Synchrotron did an amazing job, because we now have a setup for very bulky specimen. This case here was entirely filled with water, and the new rotator is still able to very accurately and precisely turn this bulky specimen around, and is also set up to look at patients. It also now gives us the opportunity to do 360-degree scans to actually capture the size of an entire chest, also in a human. But the Italians said, okay, fine, it's working with water. We still get quite good image quality if we fill the entire phantom with water. But what about the rib cage? What about bones? Is our energy high enough to penetrate the bones of a human chest? We went ahead and bought an entire pig chest with the spine. And here's a PhD student for scale. It was big. And we had to mount it around our phantom. And therefore, I had to cut it into little pieces. And that was, the Italians called it the monster. But it worked fine. We had the spine in the back. We had the ribs around the chest, and image quality did decrease. Here you can see the spine, actually with the spinal cord still inside, and the ribs were not captured here because of the field of view. That basically probed us that we need somehow to increase energy here in order to use this for patients. And to not repeat this monstrous experiment again, Christian Dullin went ahead and with the help of the Italians, basically, and a little bit of help of the Heidelberg people, designed a new phantom that has already incorporated the soft tissue and bone structure. And that's the final product. You can see the rib cage here, the artificial rib cage, and the density also of the plastic phantom itself resembles soft tissue contrast. And now you are able to do experiments very close to the condition in an actual human, and not having to cut an entire pig in half. This is what this thing looks like in a normal CT scanner. You can see the structure, you can see the vertebral column and all of the ribs, and the soft tissue density of the shell. And that's what it looks like in a classical CT scanner. Just some more example images still. You find that the fine structure of the lung, of course, is preserved. That's what a medical facility could look like in order to investigate patients in the future. And the Italian Synchrotron facility, with their legacy of having already imaged live patients for breast imaging, is a perfect spot to realize this idea of bringing lung CT to patients. I hope I gave you a comprehensive impression of what our goals are, what our pipelines and experiments look like. I want to thank all the team that I'm only one small part of this, and without each and every one of these people here, nothing would have been possible. And I want to thank you for your kind attention and hope that you have a few questions.
Yeah, thank you. That was really amazing. That was amazing to see, and thank you so much for all the clinical examples as well. That was amazing.
Sure, thank you.
Do you have time for any questions?
Yeah, a colleague texted me. He will do the the board that we are having at the moment. It's fine. You can go ahead. My telephone might ring in the meantime, but yeah.
Yeah, well, I'll open the floor for anyone if they've got any questions, or you can put it in the chat or just unmute yourselves if anybody has any. I guess, oh yeah, Tim.
Hello, Willi. Thank
Hi.
you very much for an excellent talk. That was really, really impressive. You actually already touched the issue of the dose. And also towards the end of your talk, you mentioned that you are considering using higher energies. So could you please maybe expand a little bit on these two things? What will you see as a possible acceptable dose for this high resolution lung imaging in live patients? And what X-ray energy you think is going to be optimal for that purpose? Thank you.
Sure. Let me go back to this slide to address your question. Of course, radiation dose is the #1 safety issue that we have to talk about when it comes to imaging patients in a synchrotron facility, because it's potentially lethal what you can generate with a synchrotron. What we have done to measure radiation dose was first ionization chamber measurements, and then later we went ahead and implanted TLDs into the specimens. So we wanted to find out what's the actual dose within the scanned lung region. And we used many TLDs and implanted them into the lung or the sample and put them into the synchrotron beam and also into the clinical CT while we did our scanning. And those numbers that we generated are in the very left column here in posted here. And you can see that the dose is comparable to what we achieve in the clinic. Of course, we have to keep in mind that we are looking only at a very small subset of the lung. We are conducting a local tomography. The size of our field of view can be seen in the upper row here, and the Z stack is very few. So a few millimeters only. Of course, you can stack them, but each and every stack will double your radiation dose. If you increase the energy, I believe we will have an increase in radiation dose, but probably not proportional. I would like to take a joker and ask Christian Dullin if he could help me on this one, because as of my knowledge, high energy, that the phase effect will also work with higher energy, but these higher energy photons will not be absorbed in your patient because they will go through him. And that's another perk of synchrotron CT scanning that we can exploit. But Christian, please help me on this one. Christian is my doctoral advisor, by the way. He made it possible that I got my thesis on this topic. I hope he's still here.
Excellent, thank you.
Is he not here anymore? Yeah, he is, but he's muted.
Can you hear me now?
Yes.
Yes.
Yeah. So the dose question, I think there is no real answer yet, because it all comes down what is the benefit in the diagnostic. So I think we can at the end have a little bit higher dose than currently used if we really show that this is a major improvement in the diagnostic. So there is not a real answer to that. I think the range is around 10, maybe 20 milligray, but I'm also not entirely sure about that. If it comes down to the photon energy, the only thing we know for sure is it should be above 50 keV, because otherwise we have problems to penetrate the bone structure. So the original plan was to go roughly with 60, but now we are not entirely sure if we should not at least try to go way higher and see what happens with the image quality. But this is something we cannot test here in Italy. That's the problem. So Juliana is very much interested in also doing scans at, let's say, 120, just to see what we can get from the phase contrast and in relation to the dose. So I'm sorry, I don't have a real answer yet. I can only tell you 60 was the plan, but maybe we will go higher.
Well, I guess that brings immediately another question, Christian. When are you coming for an experiment in Australia, finally?
So now we sample answer heads. Compare everything. So we will send our man on the ground now. So hopefully at the end of the year.
So sorry, I couldn't hear that clearly. The sound was distorted, Christian.
Sorry.
Hopefully by the end of the year, he said.
Oh, right.
Yes.
Okay. Hopefully by the end of the year. Excellent.
Yes, exactly.
That will be very exciting. Thank you.
Yeah, we are looking forward to this too. This was on our list for a long while. And maybe I can add a little bit to the radiation dose issue. So in clinical routine, 10 milligray, like Christian said, is perfectly normal for a thoracic CT scan. And what we actually do, especially with patients, for example, with COPD, some also with lung fibrosis, is we do inspiratory and expiratory CT scans. So they're double radiation dose right away without flinching an eye, because these people have a bad pulmonary disease, which limits their lifespan. And we always have to think about what's good for the patient. Yeah, would you do for a normal cough? You wouldn't do a CT scan in a child or a young adult. Right. Never. But an elderly patient who's suffering from pulmonary fibrosis, for example, or who has a suspicion for pulmonary fibrosis, you have to take into account that IPF has a life expectancy of down to 2.5 years. So it's worse than most of the cancers that we know, with the exception of pancreatic cancer, which is one of the worst. You always have to take these factors into account. And we are not talking about an imaging modality that will be used in young patients, in children, or for screening purposes. We are talking about a diagnostic tool that gets additional information for really critical illness and disease, and you could easily justify a little bit higher radiation exposure for a patient cohort like that.
Yeah, understood. Just a small clarification, Willi, please. Yes. These doses that you have on your slide, are they for an excised lung?
Let me show you the setup once more. It will answer your question the best.
Right.
This is the Phantom, the old Phantom. Now we have a new Phantom, better Phantom, but the radiation dose experiments happened in this Phantom.
Right. So there is no
it's a-
rib cage and no skin, right?
That's correct.
No rib cage. We hope that the let's say the bulk material of the phantom simulates a tiny bit the soft tissue, but there is no rib cage. Yes.
Right. So I imagine that affects the dose, right? When your lung is inside the body, the dose will be higher, presumably, in order to provide the same image quality, correct?
Presumably correct. But
Yeah,
Christian,
maybe a tiny bit higher. That is true. So
Christian, we use the exact same setup in the clinical CT.
yeah, no, it's a question about the tissue around, not so much about the setup. So there will be more tissue around in the patient, of course, and there will be a little bit of scattering and something else that will increase the dose. That's true.
That's true, Christian, but we did put it into the clinical CT scanner. It has an automated dose adaptation, and the dose that we measured in there, or the scanner actually used, was very well comparable with the in vivo situation in patients. But there's something to it. You're absolutely correct. It has to be repeated with the new phantom, which is simulating soft tissue and bone absorption too.
Yeah, and there's another issue that till now we use very simple filtered back projection reconstruction. So there is nothing optimized, no iterative reconstruction, nothing. And even we used a lot of projections because we had the problem that the detector was fast, but not the first rotator that we had. So we had actually more projections than necessary. So I think we have still a lot of options to get the dose even lower.
Excellent. Thank you.
Does anyone else have any questions? Well, we're past the time, so if no one else does, I think we'll call it a day. And thank you so much for joining us. I know it's really early in Germany at the moment, and you've got another long day ahead. So thank you very much, and we appreciate your time.
Thank you very much, Diana, and have a nice day, everyone. Thanks for listening and talking.
Bye-bye.
Bye-bye.
Bye.